I'm going to put myself on a timer. Thank you, Jill. Do I have the capacity to start and stop this as I go? I will tell you. I'd like to see a show of hands here. Who is a patient or a former patient? What a privilege to talk to all of you. So you can go ahead and start for me. We'll start at the beginning too. It's a good place to start. So I'm going to show you actually the video of one patient, because I don't know how many of you have actually seen. I'm sure you've probably YouTubed some videos. This is a patient that we did, 34-year-old guy who was in the hospital already for heart disease, and we walk in the room, it's clear that he's got acromegaly, ends up with diplopia from a tumor. And this was NOSP 3B. Okay, so according to the NOSP criteria, chances of surgical cure, 25-30%. Of course, NOSP was created back in the 90s. This is the technology that we're using today for this. I mean, completely different than what Engelbert NOSP was using in Austria in 1993. So Pam and I stand on the shoulders of giants, Brooke Swearingen, Ed Laws. So we have a setup now that's completely different and really has made our job much, much easier. So here we're going to go through, this is the patient's right nostril. First thing we're doing is identifying all these important structures. If I move away from this, will it affect in any way how you hear me? Can you hear me over here? Oh, exactly. So I feel like now I'm Joel Osteen from some mega church. So septum, nasal turbinates. We have to mobilize these out of the way because everything we're using is going through your nostril. So every instrument that we use bilaterally going through, and we're coming here, middle turbinate is right here, superior turbinate is here, and now we're looking for this little opening right here, which is the opening to the sphenoid os, which is a natural bony chamber that lies in front of the sella. So we're going to find this, cauterize it, and then this is a Doppler ultrasound. We do this every case. We're actually ultrasound. We want to see, have we not sacrificed the vessel that supplies the mucosa here, in case we need a flap. We're using instruments to open this up. Then we're going to open up the mucosa because we have to open up the midline to actually get into the sphenoid. One thing we don't do anymore, so I was trained by Ed Laws. What a privilege that was. Pam was trained by Brooke Swearingen, right? So these are two giants in our field, and Pam and I stand on their shoulders for sure. But I've modified some things from when I was in training. One thing I don't do anymore is I don't take any mucosa. All we do now is we open it up and we simply move it to the side, and now we have new retractors that go inside so that when we're done, we can put the mucosa right back. And that's important because A, it's better for your breathing, and B, your smell nerves, what we call the olfactory neuroepithelium, all exist way up here, and we don't want to disturb that. So once we've done this, we're going to open up this mucosa on both sides. Okay? And we're looking for this central bone that we call the vomer, which is the back part of the septum. And this, by the way, is the little retractor system that we put in. There's a little flexible net that we put in both sides, opens everything up really nicely. Because you can imagine that as you're passing instruments in and out of the nose, it'd be easy to injure things just with the instruments. This helps protect all of that. Now we're going to bring in a drill. This right here is the face of the sphenoid right here, and this is all bone right here. We're drilling that all down so that we have a nice wide access to the sella. Because in the past, right, when all we had access to was a microscope, imagine that you're trying to get into someone's brain, but you are looking through the keyhole of a door. Right, so there's a little hole here, and you're like, okay, I'm going to try to find out what's in there. This is what it's like using a microscope. And you're going to hear surgeons all the time just perseverating on this topic. But now we have instruments that have a camera at the end. We stick it through the keyhole. And now we just purchased a couple of Apple Vision Pros. Pamela, you're going to love this. And now we wear them. Research so far, we haven't done it on a patient yet. And now it's like we're standing inside the sella and we're looking around. Now, what am I using here? This is an actual ultrasound. So we have a tiny little ultrasound, just like when you got pregnant back in the day and they're ultrasounding the baby. We now have a tiny one that fits through the nose, and we can swipe it and we can look at where the tumor is or where the carotids are, optic nerves. Now we're opening up the dura. And as we're doing this, you saw us use an ultrasound to look for the carotid artery. This particular, because we know it's invasive into the cavernous sinus on the right, we know it's going to be wrapped around the carotid artery. So we are looking for it, and we use it multiple times for the case. Why do we start on this side? Because it's the easier side. This side over here is all carotid artery right here. So we've taken all the bone off this, unroofed it. We're going to come back in a second, open that up. But we're going to start by doing the safest portion of the tumor first. So you can see this tumor, they're classically very whitish. Now you see I put an instrument in and I pulled the dura away from the carotid artery because Lee Min is sitting here looking at me and is like, he's tensing up. So what I'm trying to do is open this dura up and the carotid's right underneath it. So we're going to pull it away, open it up that way, and you're going to see a lot of venous oozing from this for the rest of the case, from the cavernous sinus. And we're going to start taking tumor out of the cavernous sinus over here. And the rest of this video is going to sort of be belaboring this point. So here we have the medial wall of the cavernous sinus on the patient's left. And then over here, you're going to see us start to work with tumor inside the cavernous sinus. And I will tell you that using a microscope for this is a huge challenge. I just don't know if it's really possible to do this. So the view that we have here is amazing. In the cavernous sinus, there's multiple pockets, septations that we have to get into. So you're constantly moving into new areas of tumor, and we're looking at all those. So this is our resection cavity from the first part of the tumor. Now, as we're opening up, and you can see I'm just opening up the dura farther and farther over. We've actually opened the dura lateral to the carotid, so we can be on both sides. Then we're going to be digging out tumor in this area. And right in here, I've discovered, I found the lateral margin of the tumor. How do I know this? Because there's so much venous oozing coming from this area. So what's this again? Ultrasound. And we're just using it multiple times through the case. Because I'm thinking to myself, where is this carotid artery? We can't see it, there's tumor on top of it, but I really want to try to get a chance at a cure. So now you can see this is a septation within the cavernous sinus with tumor in it. And you see this is cavernous bleeding coming away. And I think I found a pretty good margin here. So I'm starting to just now mobilize this tumor away. And what's great on this video is you'll see the carotid artery. You'll actually see a nice view of the paraclival carotid going on the cavernous carotid. And you'll see it once we get the bulk of this tumor out right here. So as I'm pulling it away, actually I have to back up from this, it's so close. You're going to see the carotid come into view right through here, okay? We're going to Doppler it, and then once we have it in view, this is when I get the most excited. My ENT colleague, he is just standing next to me, and he's like holding his breath. For me and neurosurgeons, I'm so much more at ease when I know where it is, when I've seen it. Because then we can be very careful, and here it is right here. You can see this is the underneath part of the carotid, and it runs all the way down like this. So now we're taking the tumor off of it right here, moving it back to the midline. Once we get that out, then I'm thinking, okay, but have we removed all the tumor at the upper limit? So we got to come back in. So you can see the carotid very clearly here right now. See that? That's the wall of the carotid right here. We're just carefully, sharply dissecting this tumor off of it. Then once we have that out, this is the bulk of it that's coming out right now. Then I'm going to come back and we're going to start working on the superior limit. And I always do this because I worry that maybe we've left a little bit of tumor at the top, and it's so disappointing. I get a call from Lisa. Hey, I looked at the scan. Dr. Smith, I wonder, do you think there's tumor there? You know? I'm like, no. So we spend, by the way, I've edited this as a 10-minute video. I've edited it down from a 3.5-hour surgery, okay? So I don't want you to get the sense that we're just flying in and doing this. This takes many hours to do this. So now what you see here, I'm just looking at, now I'm behind the carotid artery. Here's the carotid in the front. I'm going behind and trying to take out the tumor that's wrapping up and over it, okay? Then I've come back to the surface now, the superior surface, and now I'm looking to pull the gland off the diaphragm. I want to see the diaphragm without creating a leak, okay? So I've found it, pulling it out, and there you can see, when I pull this back here, there's the diaphragm right there. And once I see that, I'm like, yes, now I know that there's no tumor at the superior extent of this, okay? Once we're done, now a lot of times when I go to the cavernous sinus, the exposure's so big, we end up putting a nasal septal flap up just to reconstruct the skull base. We start by taking fat, we go to the abdomen, take a little fat if we can find it. Most of you, I don't think we'll be able to. Pack up into the nose, and then we put a little bit of the mucosa down to reconstruct everything. This is showing you how we do that. It's a little bit shaky here because now ENT is holding the camera. And I've actually sped this up to 3 times the speed. So We're gonna take it off the inside of the nose. We're gonna rotate it around like this and put it up in the skull base so that when the patient wakes up, they don't have any problems with leaks. And there's my timer right there. Okay. I'd like to thank, first of all, Lisa for putting this together. I'd like to thank Jill for being so kind with her emails to me. Where's your video? Where's your video? Because I was supposed to submit this last week. So thank you very much.